Ladies and gentlemen, please welcome to the stage John J. DeGioia, President of Georgetown University, Yada Matilda Musa, Graduate Student, School of Nursing and Health Studies, Ron Klain, Ebola Response Coordinator, Executive Office of the President, and Dr. Anthony Fauci, Director, National Institute of Allergy and Infectious Diseases.
Good morning and a warm welcome to distinguished guests and members of the Georgetown community who are here to join us this morning for the forum, Ebola, Responding to the Domestic and Global Challenges. My name is Yada Matilda Musa, and I am a graduate student finishing a degree in global health. To me, the current Ebola pandemic is a very personal issue. I am a Sierra Leonean, and Sierra Leone is one of the 3 hardest hit countries in the current outbreak. As of today, there are 7,312 confirmed cases with 1,583 deaths. And according to the WHO, this may still be increasing. My immediate family is still there. This makes it very worrying. Georgetown is not only one of the world's leading academic research institutions. It is a university that is founded on strong Jesuit beliefs and values. As students, we come here from all over the world and from different cultural backgrounds. So response to the current outbreak and the challenges that they're facing is very important to the university. Our distinguished guests for today's event include Mr. Ron Klain and Dr. Anthony Fauci. Our president, Dr. John DeGioia, will serve as the moderator for today's discussion. Mr. Ron Klain is a 1983 graduate of Georgetown University and was a former editor of The Hoyer. He also graduated from Harvard Law School in 1987 and was the editor for the Harvard Law Review. He's currently the coordinator at the White House for the United States Ebola response. He has also served as Chief of Staff for Vice President Joe Biden and former Vice President Al Gore. Dr. Anthony Fauci is the director at the National Institute of Allergy and Infectious Diseases at the NIAID and has served in that capacity for the past 30 years. He's also a key advisor to the White House and the Department of Health and Human Services on strengthening public preparedness against emerging infectious diseases. I look forward to their insights, and I wish to express our gratitude to each of them for being here today. Ladies and gentlemen, please help me welcome our panelists.
Thank you very much, Yada, and thank you all for being here this morning for a very important conversation regarding an urgent challenge that we face as a global community. You know, over the course of the last year, we've been engaged here at Georgetown in a very significant conversation regarding the future of the university. How, in the face of a whole set of new disruptions that are really changing the ways in which higher education is understood and perhaps even delivered, we've been wrestling with what does it mean for us? What is it we need to protect and embrace? And what is it that we need to respond to in terms of some of the new challenges? And as we've thought about our 225-year history, and we've thought about what does it mean, what is the idea, the mission, the purpose of the university, we've identified 3 interlocking elements, 3 characteristics that serve as the underlying framework in which we do all of this work. They're inextricably linked, they're interlocking, mutually reinforcing elements. We're committed to the formation of our young people, to the inquiry, the scholarship and research of our faculty, and as a university community to contributing to the common good, wherever and whenever we can. The issue we're going to discuss this morning, the Ebola crisis that has unfolded over the course of the last 12 months, is one that has engaged our university community in each one of those dimensions. We've sought to ensure that our young people had the opportunity to understand the implications, the background, the history, the etiology of the disease, and also to understand what kinds of responsibilities do we have in moments like this. Our faculty have been engaged in a wide variety of efforts in exploring in research and scholarship the nature of this disease. And then, of course, as a university community, we gather here in moments like this we have throughout the fall, trying to understand at ever deeper levels the nature of our shared responsibilities to one another. We have an extraordinary opportunity this morning to be with two exceptional people who are, more than any in our country, responding to this challenge. And it's a privilege for me to be in conversation with them. I'm going to start off the conversation. We'll go about a half an hour with some questions that I'll ask, and then we'll bring a microphone to the center aisle, and we'll take another half hour or so of questions from all of you. But let's get started. And Tony, could you give us just, this is a disease we've known about since 1976. We've seen other iterations of it over the course of these last roughly 40 years, nearly 25 different experiences that we've had dealing with this as a global community. Over the last 12 months, we've seen a particularly intense experience. Can you give us a sense of the arc, the narrative that we're engaged in now as it relates to Ebola?
Well, thank you, Jack. Ebola is fundamentally a disease in animals that it's called a zoonotic disease that is not a disease that has adapted itself evolutionarily to humans. So it fundamentally is in animals, and then it jumps into humans and spreads by very well-defined ways. In 1976, and it likely existed long before 1976, it was first recognized almost simultaneously in Zaire and in the former Zaire, currently the Democratic Republic of the Congo, and in Sudan, in which there was an outbreak that was controlled by the way we are still today controlling it, namely identification, isolation, contact tracing, and keeping people who are sick away from other individuals, or if you are taking care of them, do it in a way where you're protected. And every one of the epidemics that Jack mentioned, all 24 of them up until now, ranging in size from 2 people to the second largest one was in Uganda in 2000, which had about 400 people. And they were all able to be put down in the sense of controlled. The arc that Jack is talking about is something that's unprecedented because of what I refer to when I talk about this as the perfect storm. And the perfect storm is you have a disease that's an emerging infection that characteristically jumps to humans that has been able to be controlled because prior outbreaks were fundamentally geographically restricted in areas that the bad news is that it was remote and it was tough to get people there, but the good news is that it was remote because it was easy to isolate. The perfect storm of the current arc is that you have now an outbreak in an area of Africa, West Africa, that has not historically seen Ebola, in a highly populated area with porous borders, where even though the artificial borders that years ago were made, that people have relationships across borders, so they're constantly going from one country to another. And when you look at the map of West Africa, Guinea wraps itself around Sierra Leone and Liberia. And also you have the issue that we've never seen before is in big cities. So we now have an outbreak that percolated a bit in the very early part of the spring and then started to explode to the point where we now have an extraordinary situation. 17,800 cases, 6,700 deaths, likely a bit of an underestimate, with waves of the epidemic. It looked like Liberia was the worst a month ago, got some better control of it that now, even though don't claim victory, because there may be outbreaks in the rural areas. And now we have Sierra Leone, which there were more cases now in Sierra Leone last week than there had been in Liberia. I mean, it was just the issue of the ARC now is doing this in Sierra Leone, this in Liberia. Guinea is kind of like this. So that's the way Ebola works. It comes in waves. So we are still, even though we're making progress, Jack, still in a very critical, serious situation. And the thing about Ebola, just finally, is that unlike other diseases, when the trajectory goes down, almost by itself, it'll disappear. Ebola, if there's one case that's out there, one case can ignite another explosion. So it's one of those unusual diseases that you have to really put every ember and every spark out. And we're far from that right now.
Thank you, Tony. Ron, Tony has spent his entire career engaged in addressing infectious diseases. In mid-October, you were minding your own business when the president called you and said, we need you to help us develop our national response. What was it like in those early days? How did you come to terms with the challenges that you faced in this new role? Tell us a little bit about the learning curve and how you were able to close some of that curve. And what have been your impressions? What have been your experiences now in roughly 6 weeks on the job?
Well, so when the president asked me to come do this, I was minding my own business. I was teaching a course here at Georgetown. I see several of my students in the front row, and it's good to see them again. But I think that, I think the president asked me to do this based on my experience in coordinating other complex interagency projects we've had in the federal government, most recently when we did the Recovery Act, almost $1 trillion in federal spending in the first 2 years of the administration. And his request was that I come in and try to coordinate what we call the whole of government response. We have virtually every single federal agency working on some element of fighting Ebola here at home or overseas. And for me, I've been able to climb the learning curve thanks to great experts like Tony Fauci and Tom Frieden at the CDC and the various other experts, Raj Shah at AID, Sylvia Burwell at HHS. And my major objective in the job is just to make sure that all of our agencies are working together, that we're identifying problems, that we're reallocating resources that needed, we're getting decisions quickly to the president for him to make about our response and making the difficult policy choices that need to be made. I think the thing that's been not so much surprising to me, but is really just humbling to me every day is the vast array of people who are acting selflessly to fight this disease every single day. And we're sitting here today in Gaston Hall, one of my favorite spots on planet Earth. And while we're sitting here, there are hundreds of volunteer healthcare workers, in Ebola treatment units, in community care centers in Liberia, Guinea, and Sierra Leone, government employees who've taken voluntary leave, reassignment to go fight this disease right on the front lines, putting themselves at risk, doing the most important work that can be done to battle this epidemic. And the chance to meet with those folks, talk with those folks, and do whatever I can to facilitate their work is the most humbling part of the job and the most important part of the job.
Tony, maybe you could take us just a little bit deeper into the perfect storm. Why West Africa? Why are things appearing to stabilize right now in Liberia but look like they're on the increase in Guinea and Sierra Leone? What is it that we can understand about the nature of this that explains some of the phenomena?
Jack, what this really brings out, and I hope if there's something good that comes out of this, is a realization of how when you do not have a minimum modicum of a healthcare infrastructure, how vulnerable you are to so many things. And then when something as cataclysmic as a highly lethal disease inserts itself into the community, do you realize how that lack of infrastructure and ability to do just minimum healthcare type delivery can be so destructive to a society? So what I hope comes out of this is a realization by the countries themselves, but the world, the wealthy countries, the organizations, to realize how we can build sustainable infrastructure. You've heard Ron and I and Tom Frieden and Sylvia Burwell and others say, not in a cavalier way, that it is highly unlikely. You don't say impossible because you never say that in biology. Highly unlikely that we would have an Ebola outbreak of any significance in the United States. And the reason is because we have a healthcare system that won't allow that to happen. So one of the things that is so important for the world to realize, that we will end this outbreak in West Africa in collaboration with our West African partners. But this would be a terrible thing if we let the opportunity go by without saying we need to then leave an infrastructure there, or the beginning of a direction to an infrastructure to not only prevent Ebola, but what about malaria? What about tuberculosis? There are things there that can, I wouldn't say easily, but that can be addressed just with a modest turning of the knob. It's amazing how many people who we are following that we want to make sure they don't have Ebola, that have malaria. So it really hits you right between the eyes that malaria is taken so for granted, and yet it kills close to 700,000 people each year, almost all of which are African babies. So this has got to be a shake the cage moment for us to realize that.
And if I could, Jack, just add two things to that. I mean, I think, building on what Tony said, one of the other tragedies of the Ebola tragedy is the collapse of the healthcare system, such as they were in these three countries. The level of immunization has plummeted to near zero. The level of prenatal care is plummeted dramatically. I had the honor and the sad duty of speaking at the funeral of Dr. Martin Salia last week, who was a missionary physician in Sierra Leone who was not treating Ebola patients, but died from Ebola because the level of infection in the healthcare system is just so high. So when we count the number of deaths from Ebola in these three countries, we also need to count the other kinds of human loss in these countries from the rise of other healthcare problems. So that's one point I'd say. The other thing is, and I'm sure we'll talk about this more, but the president has submitted an emergency funding request to the Congress, which has been getting very favorable consideration. We're very grateful from both Democrats and Republicans for their response to this. But part of that request is an investment in a global health security agenda to build the capacity to detect outbreaks like this earlier in other countries and to get on top of them a bit earlier, so we don't see the kind of escalation, hopefully, that we saw in these three nations.
Just building, Ron, on that point, the first death, I believe, was a year ago tomorrow. And as we were describing earlier, through the course of the spring and summer, the numbers really began to climb. What have we learned about our global governance, our capacities for global governance on issues like this? Because it did take some time for us as a global community to respond effectively.
Well, Ron just mentioned the global health security agenda. If we had a functional global health security agenda to be able to recognize those first cases in Guinea in December of 2013, I would say with some degree of confidence that we would not be where we are right now. We would have been able to do the kind of identification, isolation, and contact tracing that could have actually put that out.
Let me ask you, though, both. What are the tools we have available to us for constructing a global public health security agenda? What kind of resources, what kind of institutional structures? Where do we go to put this in place?
Well, I think clearly we have to work with the WHO and the other international organizations. They're an important structure for all this. But I think that, in this case, America has to lead, and it has led. And I think it's led for three reasons. I mean, first of all, this is a health problem for the United States, too. As long as there are people getting Ebola in West Africa, we are from time to time going to have people get Ebola in the United States. Not an outbreak, not an epidemic, but occasional cases. We're going to have healthcare workers come back to the United States infected. So this is a healthcare problem for us. Secondly, it's a geopolitical and national security challenge for the United States. To see this kind of devastation lost in West Africa, that's something we have to respond to. And finally, obviously, it's a humanitarian crisis to see this kind of loss of life and devastation. So the United States has led this response. We've had great partners. We're seeing a great response from the United Kingdom, from France, even non-traditional partners. China, I think, has mobilized its largest global health response in response to this crisis. We have doctors from Cuba working in Sierra Leone right now. So it has been a global response, but I think our leadership has been critical, and I think it's something the American people can take a great deal of pride in.
Thank you. If there were other elements in the current structure for addressing a challenge like this from a global perspective, are they needed, or are there existing elements in the structure that just need to be used more effectively or efficiently?
Well, we need to expand what we have. You cannot underestimate what it means to have a country be able to do it themselves ultimately. I think the classic example of that, and it was really almost the foundation for so many other things, including when we developed PEPFAR, is that there are many people who do this well, but what Paul Farmer did in Haiti and Rwanda, where you just don't go in, help people, and then get out, but you go in, you train people, and you make a situation there where they will stay, they will teach others, and it will become a self-sustaining issue where, you know, you do it, you train someone, they do it, they train someone. We had that experience in a very positive way 30 years ago when I first became director. We set up a unit of exchange back and forth in Bamako in Mali, and we had trained people who were actually global health students who came from Mali to the NIH, and then we went there. And that turned out to be an interesting model because it started off focusing just on malaria. Now, the people who were trained there and who trained people, and on, that in that area, they have an infrastructure there that made it very easy when the case went to Mali to all of a sudden contact trace 300, 400 people. They never would have been able to do that if they didn't have that. So we really need to continue to make it sustainable in the countries that are involved.
There is a bit of a mismatch, 17,000 cases in West Africa, 11 in the US, and yet the public discourse that unfolded here in the US in the days shortly before your appointment, what have we learned about how difficult it is to communicate, to engage in public communication about risks like this?
Well, I think, Jack, it's understandable when people hear about something that's new and dangerous, that we've never experienced in our country before, to react with trepidation about that. And I think the best thing we can do in the face of that kind of anxiety is to respond promptly with an aggressive response, but a response based on science, on medicine, on the best possible learning that we have about this. And so, I think our country was very, very lucky to have someone like Tony Fauci. It's a great experience. As a person who won our nation's highest civil honor 6 years ago and is still fighting this fight every day. And to have his leadership and expertise and wisdom and voice, I think, has been a critical part of that. I also think we simply had to, people had to experience our success in managing this disease to have confidence that we can successfully manage this disease. The fact that all 8 of the patients with Ebola who've been promptly diagnosed in our country have been treated, all treated successfully, all survived the experience, all back home with their families now, I think has also been a reassuring thing, but something people couldn't know when they were hearing things like this is a disease with a 70% death rate. So I think a combination of great communication from great experienced leaders, policies based on science and evidence and medicine, and then proven success in isolating, identifying, and treating cases, I think have been the key things in bringing that public anxiety down.
Anything you want to add, Tony? Tony, as Ron said, you've been at this for a while. This is 30 years you've been leading the Institute. You will forever be remembered in our nation for the leadership you provided during the most difficult and challenging moment when we were confronting HIV/AIDS and really trying to sort that out as a nation. Are there things that you're bringing from those experiences? You mentioned PEPFAR a moment ago, but are there things that you're bringing from those experiences in the 1980s and 90s as you wrestled as director of the Institute with the HIV/AIDS crisis to this one?
Well, there are several. I think one that you alluded to, Jack, that it's important is the idea of consistent, honest, open communication of what you know and what you don't know. Don't ever be afraid of saying you don't know, balanced against trying to seem like you're smart and you know when you don't, and then your credibility goes down. The other thing is to try and communicate in a way that is always science and evidence-based. And you may not get it across the first time you say it, but you've got to say it over and over and over again. And that is the issue of risk and probability, and to try and explain to people that the risks of things are there. We've got to accept that. We had a lot of anxiety, as Ron mentioned, understandable anxiety. You never put anxiety down, you never poo-poo it. It's understandable. The way you counter that, the way we did with HIV in the 80s, is by scientific facts over and over again. And I bring the analogy because it's so striking. I had been intimately involved in both, is that we're trying to communicate to the people that this virus is transmitted by direct contact with bodily fluids, blood, feces, vomitus, things that people don't like to talk about, which is the reason why healthcare workers are the ones that are most at risk, because they put themselves, they run into the fire, not away from the fire, and that's why we have the risk translated into infection. That gets extrapolated by the American public. When they see Ebola, they think somehow everyone is at risk, and you've got to keep telling them the scientific facts, argue that they're not. I remember so clearly, Jack, being on Ted Koppel Nightline, trying to explain to someone who was arguing against me that the risk, this was 1982 and 83, the risk, they say, well, why don't we not allow gay waiters to wait on tables in Greenwich Village? Because we know now that a substantial proportion of them are infected. So what happens if they have a cut on their hand, they put a plate down, you have a cut on your hand, you pick a plate up, therefore you can get HIV. People were actually focusing on that. So you had to say the scientific evidence. Is that possible? Yes. But do a probability curve. It is more likely that you will get hit by a car as you walk out of the restaurant than it is somebody giving you HIV that way. And you had to just keep going over and over. And then finally, when all the scientific data was in, people believed it. That's how you counter. You've got to be calm. You've got to never be pejorative of people who actually disagree with you, even though you think they're unreasonable, and just keep countering it with scientific-based evidence, and it works.
Can I add just one thing, Jack? Sure. Particularly here at Georgetown, I think the key to this response is a unique combination of science and faith. Science, as Tony indicated, being medically aware and having the best policies based on the best science and the kind of information Tony talked about. But as with the HIV/AIDS crisis, the role of the faith community in preaching about compassion, about tolerance, about non-stigmatization, about volunteerism, about service, that's also a key element of the response. One of the first meetings I had at the White House was with faith leaders from all faith denominations that are sending people to volunteer in West Africa. Dr. Kent Brantley, who's now become a face of recovering Ebola cases here in the United States and who's donated generously of his own plasma to help treat other people, he was there on a missionary mission in West Africa. So, sometimes we at places like Georgetown, we wonder, how do faith and science go together? How do we reconcile these two things? And the Ebola crisis is a crisis that shows us that we need both these things to address all elements of the response and all elements of the crisis.
I think you both have captured a couple of very important points I'd just like to explore a little bit further before we open it up. Ron, in mentioning faith, identified the role that communities play in helping to control the spread, the arc of an illness. In the 1980s, many communities came together to complement, supplement, support the work that colleagues were doing in the science to create a more immersive context in which to respond to some of the dynamics of the illness. Right now, one of the organizations that's been on the front lines has been Doctors Without Borders. And they do seem to borrow some of the efforts that you were describing with Paul Farmer's work of bringing a whole community into the work. Could you say just a little bit more about your own experiences in trying to mobilize the power of communities in support of responding in moments like this?
Well, the thing that I have most experience in, obviously, is in HIV, because it was so pervasive. I mean, we've had the anxiety of Ebola, and we've had a handful of cases here. Back then, we had tens of thousands of cases, and not a lot of people were paying attention to it early on. So when you talk about community, I think the involved and caring community, mostly the activist community, have transformed the way we look at diseases now in the United States. So it's a little bit different because we don't have or need that with Ebola in the United States. But I can tell you the reason that we have the success in Southern Africa with HIV is that the activist community in Africa borrowed a page from the playbook of the activist community in the United States and said, there are drugs out there, they are making people well, we're dying, we need those drugs. And that's the reason why we had the evolution and PEPFAR, and the President Bush stepped to the plate and did what he did. I think now, if the communities in Africa, and I know they're very stressed because there's government dysfunction, there's civil wars, there's a lot of things there that are dysfunctional, but if the community makes the demand for the kind of systems, the kind of infrastructure that we're talking about, I think, Jack, that's going to go a long way to making it happen. There's nothing like a community that gets together with one message to change the way leaders look. It happened right here in the United States with HIV and the AIDS activist community. Why not happen in Africa about health care?
Let me ask two quick last questions, and then we'll open it up. First, on funding. Roughly $2 billion has been committed by the international community, the U.S. responsible for a good quarter of that. At the same time, the UN and WHO have outlined a pretty ambitious plan to try to bring this into control by January. Is the level of funding, roughly $2 billion that have been dedicated by nations from around in the EU, is that sufficient to respond to the crisis?
No. So it's not. And that is why we've been moving forward on a number of fronts, Jack. I mean, first of all, we continue to solicit contributions of both people and resources and funds from all over the world and from all kinds of international organizations. I also think it's worth remembering there's also, not tallied in that, a fantastic response from non-governmental organizations, foundations, nonprofits, generous benefactors here in our country and around the world. That's also part of it. But critically, President Obama asked the Congress the first week in November during the lame duck session to consider an emergency funding request of $6.2 billion, $4.7 billion for immediate use, a $1.5 billion contingency fund in case the disease changes in ways in terms of going to other countries or having unanticipated needs, as well as some unanticipated needs here at home. And we've had some progress so far. We're really hoping that in the next week, as Congress wraps up its omnibus spending bill or whatever structure they put the spending bill in, that a large chunk of that emergency funding will be passed. We need those funds urgently. You know, the response that the U.S. has mounted with all of our agencies doing something has really been on kind of borrowed money, been reallocating resources, reallocating people. No one a year ago had Ebola response in their budgets. And so to the extent we've sent hundreds of civilians to West Africa, thousands of service people to West Africa, all that's come by moving resources around. Those resources are running out, and the only way we can keep up the response, let alone expand it to do what we need to do, is by getting this emergency funding request approved.
And Tony, in your earlier comments, you mentioned the importance of a vaccine. My colleagues here will no doubt attest that I never allow an opportunity to go by where I don't make a pitch for increased funding to the NIH that works its way back to our colleges and universities. But
you're right, he never misses an opportunity.
But this disease was discovered in 1976, and we don't have a vaccine. Right. Can you tell a little bit about the background context for that?
Absolutely. We've been working on a vaccine since actually 1999, 2000. When I recruited the team from the Vaccine Research Center that came here, our first paper was in Nature in 2000 by Nancy Sullivan and her colleagues, Gary Nabel. And we, in an iterative way, were making a better and better vaccine. We never were able to get a serious pharmaceutical partner for the simple reason that they didn't perceive it as something that would be a blockbuster. When you have, from 1976 to now, 24 outbreaks for a total, excluding the current outbreak, of about 2,300 people. So no one wanted to invest in that. And I think that's one of the roles of the federal government. You know, people talk about, oh, the federal government stay out of our way. This is one of the roles where the federal government took the ball and said, we're going to stick with this, we're going to develop it, and then finally, when things started to percolate, then we got good pharmaceutical partners. But if we had not been involved in that, and again, it's a lesson that if you really want to be prepared, one of the things that's so difficult, and I've been frustrated for a long time, it's very difficult to get money for something that hasn't happened. You know, when something happens, people say, what were you doing? Why weren't you ready for it? But when you say, guess what? We need to be ready for a pandemic, flu, or what have you, it's, well, you know, we got priorities, the budget is flat, et cetera. And the same thing with the pharmaceutical companies. They want to have something that they know is going to be used right away.
All kidding aside, the reality is that the level of funding for the National Institutes of Health was significantly impacted during the sequester. More than $1.5 billion was removed. We got $1 billion back in January in the new budget reconciliation, but we're still below 2012 levels. And that's not a trajectory for us as a nation if we're going to be able to respond to the kinds of challenges that we face. We're going to open this up now. There's a microphone in the center aisle. And if you'd like to ask a question, if you could just get in line behind the microphone, and we'll take as many as we can in the next 25 minutes or so.
One of the topics...
Please introduce yourself.
Okay, I'm Burl Radin. I'm a member of the faculty in the McCord School of Public Policy. One of the topics that wasn't really discussed so far is the relationship between science and politics. And we've seen the difficulty in the U.S. system of dealing with one aspect of the political role, which is the structure of our system, federalism. And I wondered if you would comment on that, and also comment on some of the other lessons that you might draw on the relationship between science and politics. Thank you.
Thank you.
Well, I think that we do have a federal system, and in the popular press, I'm referred to often as the Ebola czar, and I never feel as unzarry as I am when we're trying to deal with this complex patchwork of federal, state, and local authorities who are involved. That said, our response in the United States is incredibly benefited by the hard work of many state and local officials too. And so this is a two-way relationship. Right now, we have about 1,400 people who have traveled from West Africa in the past 21 days, and we monitor them twice a day for their temperature. That's done by state and local officials. Our local public health authorities take on that work every day and make a big contribution to this effort and keeping the rest of us safe. And obviously, as we've rolled out our system of Ebola treatment centers, we just announced earlier this week at the NIH when the president was there, 35 hospitals, 53 beds. Those are set by federal standard, but by state and locals designating, reviewing, approving the hospitals ready for that. So I think the federal system, has worked for us for 225 years, and I think has some days frustration, but many days great benefits to us. Science, I think, it has been the centerpiece of our response in the administration. It's been the guidepost for us. And I think by and large, that's been successful. I think that, as Tony said, translating these scientific ideas into a public discussion is always tricky. We've been very lucky. I want to repeat myself on this because it bears repeating. Very lucky to have someone like Tony who has an incredible level of expertise, but a great ability to explain this to lay people to help make that bridge between science and popular discussion. And we just need to keep on that dialogue, and I think that dialogue can be successful.
One thing, Jack, though, we should be careful to not always equate politics as a dirty word. We live in a political system, but the political system really works a lot sometimes. Politics is politics, but it does work. It does work.
Thank you. Please introduce yourself.
Hi, my name is Dan Corey. I'm a senior in the college here. This question is for Dr. Fauci. First of all, it's an honor to speak to you as a fellow graduate of Regis High School. We have a couple other guys in the audience here. My question has to do with Ebola and something we've learned in one of our classes here at Georgetown. In my Biology of Global Health senior seminar, we learned about neglected tropical diseases. And one of the topics that came up in class was, could Ebola be considered a neglected tropical disease? And it's a point of debate because it has certain qualities of a neglected tropical disease, but is missing a few key ones. So I was just wondering what your opinion was on this debate, whether or not you could consider it a neglected tropical disease.
The answer is certainly, by broader criteria, it is a tropical disease and it's neglected because we don't have the tools right now that we wish we did have. Neglected tropical diseases are given different, as you know, because you're studying it, different definitions falling into the different category. But I look at it much more loosely. I would consider this as something that now it's going to be considered by the world as a neglected tropical disease because it's on everybody's radar screen. And the one thing I do hope we get out of this is drugs that we prove work and a vaccine that we know works. If there's one silver lining of tragedies like this, is that you get something out of it so we don't have to go through this the next time. So the answer to your question is, in my mind, it's a neglected tropical disease.
Thank you.
Yes. Hi, good morning. My name is Nicolas Alonso. I'm a junior in the SFS. I was wondering if you could speak about the case of Thomas Eric Duncan and whether his life could have been saved or not, and there was a lot of debate surrounding the case, so I was wondering if you could share your opinion.
You really can't make those kinds of predictions of, having taken care of so many thousands and thousands of patients in my life to say, we could have saved his life if we did this. There's always the possibility. The man was sick. He went to an emergency room. He was not immediately diagnosed. It's tough to be pejorative about that. It's easy for somebody in an easy chair here in Gaston Hall to say, well, an African man comes in, he says he feels sick, you're in the middle of an Ebola epidemic. Emergency rooms are very busy places. It was unfortunate that he was not diagnosed early. He got in, and when he got into the hospital, he was really very, very ill. Had he been plugged into an intensive care system earlier, could it have made a difference? Possible. But we shouldn't look at it that way. We should try and look at lessons learned from that. So I don't think we could definitively say that things would have been different, though it's possible it could have been.
Thank you.
Thank you both for coming to speak to us today. My name is Emma Cohen. I'm a senior in the School of Foreign Service. You both touched on briefly the role of MSF in the Ebola outbreak. I was just wondering if you had any thoughts on why there was such a discrepancy between the MSF response in calling the outbreak unprecedented in March and the WHO's response waiting till August to declare it an international health emergency. I didn't know if you had any thoughts about why we saw this happen. Thank you.
So that's a tough question, because I've always been known, and still am, a straight shooter. I think if you look at WHO has suffered from chronic underfunding, and one would have hoped that they would have recognized very early on that this was something that really was going to explode. They didn't have the manpower. They have had to, by budgetary constraints, have substantial cuts in their experienced personnel. So what MSF, which is a fantastic organization, they're there, they're on the ground, they see it as it's happening and as it's unfolding, and they called it correctly very early on. I believe if the WHO had the strength that they should have had at the time, that they probably would have been much more intensively involved in there on the ground.
Hi, it's a pleasure to speak to you both today. My name is Rosa Kapari. I'm a sophomore in the School of Foreign Service. As a student of anthropology, I've been taking careful note of how the media has been reacting to the Ebola crisis. And so I was just wondering why you both thought, because the media is a big part of the US response, at least on the ground, and we've been seeing this high level of anxiety, but why do you think there's been such extreme levels of stigmatization and othering? In my home state of New Jersey, we had an issue with well, a lot of issues, but in particular, 2 school children from Rwanda who were almost kicked out of school. There was a school teacher in Kentucky who had visited Africa and was forced to resign. Why is the Ebola crisis triggering such high levels of othering? Is it, with the recent events in Ferguson, is it a marker of racial tensions? Is there something else going on? What do you guys think?
Well, I'm not an anthropologist, and so what I would say is I can't really explain why the reaction to Ebola has been what it has been in America. What I can say is what we've been doing to try to address that. And so we've been working very hard to make sure that those who are involved in treating the disease, both overseas and here at home, aren't subject, and their families aren't subject to stigmatization or ostracism or anything like that, but are celebrated for what they are, which are heroes. And I think part of this is just a need to do more educating, more informing about, as Tony referred to earlier, the low level of risks that are involved here, and getting people more aware and comfortable with that. But we've seen this for even healthcare workers in America. The people at Bellevue who treated Dr. Spencer reported that many of them and their families were having negative reactions when they went back home and whatnot. So I think it's an important thing for all of us to do, to speak out against that kind of stigmatization, to valorize the healthcare workers who are going to Africa to fight this disease. Those people, the people who are volunteering, the people in MSF or Paul Farmer's group or IMC and all these groups that are sending people over there, those are the people who are keeping us safe here. They're doing great humanitarian work, they're saving lives, but if nothing else, we should think of them as the people who are keeping us safe here and welcome them home with the kind of welcome they deserve to be given when they come back from that.
Tony? So one of the things that I've learned, it was tough for me to accept it, but after you see it a lot, you do. Fear is a raw emotion that sometimes gets people who otherwise would be considered as good people to do things that are not so good. And I saw it in spades in the HIV/AIDS epidemic. Now, obviously, there are shades of racism and other things that might be going on. But I don't think that's the predominant motivating force. It gets to what I was trying to explain before about the issue of how the public perceives risks. We go through risks every day of our lives, but the risks are chronic and you accept them. For one reason or other, which anthropologists, budding anthropologists like yourself probably know better than I, that when there's a new risk, even if the risk in a probability prioritization is much lower than the risks that you're already accepting on an everyday basis, for strange reasons, you react much more violently in your mind, metaphorically, against that risk, because you don't like a new risk, even though you're already living many, many risks. So the one that was very, very clear, there were many, but back in the AIDS days, when children of an AIDS patient or Ryan White, who was a young man who was a hemophiliac who got HIV, they tried to burn down his house. They wouldn't let him into school because the fear of this unknown disease, even though the risk was much less than any of the children who didn't want to go to school with him. Probability and risk. The probability of their getting HIV from Ryan was infinitely less than them getting hit by a car going to school. Yet they wouldn't let Ryan White into the school. So fear does really strange things to people, and that's something that is deep-seated in our nature, and you know, it's part of us, unfortunately.
Hi, my name is Andrew Meshnick. I'm a history major in the college, but I'm also a biology minor. And I was wondering whether this crisis, which has been such a nexus of the science and political systems in the United States, whether you think that this Ebola crisis or a similar crisis will create the political and economic will to fund research into these neglected diseases, whether they're tropical diseases or not, and really make that a national priority that's bipartisan. How would that go? What mechanisms would we need to create to ensure that these are priorities, and how would we go about that?
Well, I think it already has. That is, I think that when you look at the progress we've made, hopefully on a bipartisan basis in getting the President's emergency funding request through the Congress, a lot of that money is going to go to NIH, to hit Jack's plug, and to other parts of HHS and to this global health response that I think will be investments in dealing with our immediate crisis. That's why they're an emergency, but also in making investments in more long-term approaches as well. I think it's important. You know, the President was at NIH on Tuesday, and the point he made there, which Tony and I were talking about on the way up here, was how this crisis shows the importance of basic science, of investments in basic science. If you decide the day after Ebola first appears on the front page of the New York Times that it's time to do the basic research into building a vaccine to treat Ebola, you're 10 years too late. And so a lot of this response hopefully shines a spotlight on the need to be making these basic investments well in advance of the crises so that we can deal with these crises as they arise. And to see someone like Dr. Nancy Sullivan at NIH, who I've now met twice, who've been working on this for 15 years, and probably for the first 14 years of that was one of the most obscure people in science, and in the past year, you know, is now one of the most prominent people, just shows you how long this takes and how important basic science is to dealing with crises like this when they arise.
So we're coming close to the end, so what I'd like to do, if I could, is ask the next three people, if you could ask your questions, each of you, and then we'll try to see if we can give a response to them all after we've heard from all three. So if you could be quick in articulating your questions, that would be great.
Hello, my name is Sebastian Silva. I'm a senior in the School of Foreign Service. So what specifically has been, or what has the medical community, what has the Washington community, so to speak, what has been learned specifically from this crisis looking forward in terms of identifying the next risk or how to respond to the next risk?
Okay, next.
Hi, I'm Mariana. I'm from the School of Foreign Service, a senior as well. And I wanted to talk more about the relationship between underdevelopment, poverty, lack of infrastructure, both in the medical and the government in these countries, and the current crisis. So what is being done and what could be done to actually have a sustainable approach to Ebola, addressing lack of capacity of the states?
Okay. And last question.
Hi, my name is Kelsey Staffstrom. I'm a master's student in the Biomedical Science Policy and Advocacy program. My question is how Ebola will act as a precedent on the global health platform and how it's basically going to set the stage for how people are going to react to potential outbreaks in the future. Thank you.
Okay, so we've got lessons learned, capacity, and
no, you were prescient because all of the three questions are linked, and it linked. What have we learned? What about the global, the approach to global health? It relates a lot to what Ron and I have both been saying about its dramatic experiences like we're going through right now, which underscore what people have been saying for some time of building not only the kind of healthcare infrastructure, global health security agenda, infrastructure, PEPFAR-like approaches, not only from a health standpoint, but from a research standpoint. You know, the investment in research that will not have us to play catch-up all the time, and the investment in a health infrastructure that not only will detect these diseases earlier, but will allow us to respond earlier. And that's really what a lot of the global health agenda is all about.
Well, I really can't add much to that other than to say that it is a sad fact what a large role poverty plays in the fatality rate from Ebola. I think when this crisis started, everyone read in a newspaper that Ebola is a disease that kills 70% of its victims. Well, that is true without treatment and without interventions. Even in West Africa right now, some of the NGOs that are treating people with nothing more complicated really than giving people IV rehydration are bringing the fatality rates down to 25 or 30%. That's still horrible, but when you think about the fact that you could cut the death rate of a disease in half by giving someone the most basic kind of health care, it just shows you how important, what a role resources and building up these healthcare systems and helping these underdeveloped countries get to a basic level of care, what a huge difference that can make. If you could cut the death rate from Ebola in half by giving people IVs, not the super sophisticated stuff Tony's been doing when he treated Nina Pham here at NIH or the other things that they're doing at Emory in Nebraska, but just very basic care, that's a telling fact and a telling anecdote about this. So certainly we need to make the investments in getting our healthcare system here in the United States ready to deal with infectious diseases in the future, but we have to invest in countries around the world in getting that global health infrastructure in place and trying to address some of these long-term development issues as well.
One last question. So classes are ending this week. We go into exams next week. We're going to then be off for a little while. We'll be back in about a month. Advice for us as a university community. Are there things that you think a place like Georgetown could be doing in the spring semester that might contribute to the effort to respond to this challenge, this really urgent challenge that is particularly facing West Africa, but raises a number of important questions beyond that that require our attention? Any advice for us as a university community?
Well, I wouldn't recommend you all go and try and take care of patients, that's for sure. But I think to develop, as part of experience in global health, a solidarity with the young people in those countries to try and get them to realize that the young people here care about what's going on with them. And I think you can do that through various organizations, volunteering or even doing it by just communications. It meant an awful lot to the people in Southern Africa when we reached out to them in the AIDS epidemic without even going over there, but encouraging them in their fight against AIDS and their pressure that they put on their own governments, particularly in South Africa when their government refused to allow drugs to be distributed because they didn't think that HIV caused the AIDS, they were communicating with our young people who gave them actually the fortitude to go ahead and just demand it, which they did. Right.
Yeah, Jack, I mean, I would add to that. I think that, one, I think it's great that all the different schools at Georgetown where this is an appropriate discipline study what happened in this case, domestically and overseas, and learn. You know, you can't learn from crises like this if you don't study them, if you don't learn about them, and if you don't have then academic work that kind of communicates that and disseminates that. So I think that's an important project. I think that being voices for dealing with some of these stigmatization and ostracization issues is things that students and faculty in the Georgetown community can do, both here at home and overseas. And I think it's important for Georgetown as a global university to make sure it's engaged with people from these three nations. Having Yetta here talk about her experience from Sierra Leone and have that experience here in our community at Georgetown and being able to be a bridge between our community here at Georgetown and those communities is an important part of that. More of that interchange will make us better as a community at Georgetown and make this response in the future a more effective response.
I want to thank you both for being with us today. This has been an extraordinary moment for our community to have a chance to be in conversation with you both. We're grateful to you for the leadership you're providing our nation and our globe at this important moment. And it's a real privilege to be able to have you with us. Ladies and gentlemen, would you please join me in expressing our gratitude? Thank you.
Thank you, Jack.